Hi, and welcome to everyone. I think people are slowly joining us still, but we are up to 25. Thank you all for joining us and spending this afternoon. We're very fortunate to have Dr. Feroz Ganchi, who's actually a consultant in trauma surgery in the Luthuli Hospital, in Albert Luthuli Hospital in Durban. But he's not here because of his surgery skills, but in fact because as a humanitarian, as a generalist, he has been going around in the community of Durban with this very challenging second surge and going around in Durban trying to help people in their homes. And he's here to share some of that experience. He is, together with colleagues of similar interest, have been doing great stuff in Durban. And I thought as clinicians, it would be very interesting to understand how they're going about it, what are their challenges, what are the clinical protocols, and exactly what are they managing to achieve. And so I'm very grateful, Dr. Ganchi. Feroz, really appreciate you. Assalamu alaikum. So Dr. Ganchi will present. He's got quite a few slides to share, lots of information. But please, before we go, sorry, I didn't introduce myself, Jhb Musa from the Johannesburg Health District, and this is a CPD meeting of the Johannesburg Health District Department of Family Medicine. So in terms of using Zoom, I'm sure most of you are familiar. Please raise your hand if you do want to speak, but otherwise use the Q&A function. There is also a chat function in which you can share any thoughts or reflections. We'll hopefully have a chance for Q&A at the end. So please submit that. So thank you very much, Feroz, once again. You can proceed, Feroz.
Good afternoon to everybody. Thanks a million, Professor Shabir, for inviting me, and welcome to everybody. This afternoon, I'd like to chat to you. The title of the topic is COVID-19, Care Without Access to a Hospital Bed, and its experiences from the KZN. Yeah? And the objective of the presentation today is, that there's many medical protocols around and that are being used currently. And that's not the intention for us to change or analyze any of these. However, a complete system, has been put into place to provide comprehensive care for the patients. And we're going to go through that system today. And hopefully the eventual outcome of this is that going forward, the mistakes that we've made in trying to establish the system will not be repeated by others. Overview of the group itself. There's their aims, their goals, and their objectives at the onset. What they intended to do, and eventually where they ended up, or how the group functions, the challenges faced by this group at each level, and then a way forward. The intention of the group is to coordinate home care for the patients. It was aimed initially primarily to those who cannot afford treatment. And it was funded by private donor group. Now, as the number of COVID cases rise and hospitals became full, the need for home care became critical. Problem was, proper home care can be too expensive for many. A group of businessmen and doctors then got together from the community and they commenced a home care funding program for those in need. And initially at the onset, it was that pay for blood tests, that pay for x-rays, that pay for limited medication and other costs related to the COVID, This is part of the advert, so just ignore the bottom two sentences, yeah. And this was the initial advert that was put out. So had you required any assistance, send a WhatsApp message or a text message to this person. And from there it would get processed, and we'd go through the process as to how it would get processed and further advanced. Yeah. Basically, an overview and a summary of how the group functions. It's been divided into three sections. One is the administrative side. The second was the triage group, and the third was the medics group. And each of them has their own functions, and we'd go through it. Yeah. What would happen is a message would come through. The admin group would assess the message and do their job, then hand it over to the triage team. They would then decide whether the patient needs a face-to-face initial assessment or it can be done by telemedicine. And either the face-to-face or the telemedicine doctors would then obviously assess the patient, do laboratory investigations if necessary, order an oxygenator or start the process for the patient to get an oxygenator where it needed, order medication, prescribe the medication, and do follow-up on this patient until the patient is either discharged or treatment was escalated and the patient was admitted to a hospital. The admin group, their responsibilities obviously was for coordination of all the activities. So from the patient referrals to coordinating the issues of the doctors, to coordinating issues of the oxygenators. Obviously, record keeping was important. They created a database of the patients, and then patient allocation. So either the patient would get allocated to the face-to-face team, and then when the face-to-face team would refer it to the remote team, this would be done by the administration team. And then the issue of finances, considering that it was a privately funded system, the finances would be controlled entirely by the administration team. And then obviously regarding to issues dealing with the pharmacy, the laboratory, the oxygenators, so establishing accounts, sorting out their accounts, how patients get there, do patients pay cash and do we remunerate, or do they then put it onto the account of the organization? All those issues were sorted out by the administration team. For example, this is one of the documents the administration team put together to provide to patients. It's a list of the nurses that would do home visits for nursing care, for bloods, for the organizations and people who were doing oxygen concentrators, for somebody if they needed an IV access and a drip at home, for testing, both COVID testing. The administration, we realized it was useful for them to have both medical and non-medical personnel on board. Almost all the activities were done electronically. The important thing is they would assist in minimizing the wastage of resources. Unfortunately, lots of that around at the moment. With financial, material, and any other resources, they made sure that we wasted almost nothing. A common problem was duplication. Unfortunately, with this pandemic, patients would want a second opinion and a third, and for that reason, lots and lots of resources would get wasted. The medical people would advise the administrative staff, and the administrative staff would likewise advise the medical team with regards to administrative issues. Obviously, their primary responsibility was accountability to the donors, and obviously answerable to the Lord above. The challenges that the administrative team, like I said, duplication of services was a major problem, and they tried to weed this out. Then the issue of equipment. Unfortunately, again, it's a time ripe for the market where many people can cash in, and lots of inferior quality equipment, everything from oxygenators to poor quality pulse oximeters to, all came presented, they were well advertised, and yet they'd be inferior quality. So it was their responsibility, with obviously feedback from the medical staff and the patients, to try and weed out these inferior quality equipment and supplies. And then the issue of allocating and managing financial aid to the patients, quite an important decision that needed to be taken. So the administrative team would do an investigation. And obviously, sometimes it would be helpful to check the doctor who does the face-to-face visit of the patient, if that was the case. And then they would decide whether or not this patient is eligible for financial aid. And obviously, with regards to financial aid, to what extent, is it just bloods? Is it going to be medication and bloods? Is it going to be medication, bloods, and laboratory, including oxygenator? So all of those decisions would get then taken by the administrative team, and they would manage it as such. And like I mentioned on the previous slide, they would then manage the accounts with the external service providers. So pharmacies were brought on board, and they set up accounts with the pharmacies. So if we needed medication for people who were on the financial aid package, then you would send a prescription through. The pharmacy would then either provide it and put it on the account of the group, or the patients would pay cash for it and the patients would be reimbursed. Regarding the triage group would receive the calls and they would decide the appropriateness of the referral. You'll see why I talk about the appropriateness of the referral when we come to the challenges, yeah? If the patient fulfilled the criteria of the group, then their patient information will be put onto the medic's home group. And the important thing would be prioritizing patients' needs. overwhelming number of patients. When the advert went out, it wasn't even done on a big scale. It was an overwhelming response that we got from patients calling in. Then patients would be classified as those requiring face-to-face versus remote care. Now, the triage team, obviously, for this reason, would need both administrative staff and obviously medical staff. The more experienced ones would then go on to this. Then the allocating team was another team as a subdivision of the triage team. Yeah, what would happen is then patients would then be allocated to a practitioner to follow up care. So it's either the face-to-face team that would continue care to the end, or the face-to-face team would see the patients and then hand it over to the remote team to continue care at whichever level that was then necessary. And the challenges that the triage team faced is that many non-COVID patients required assistance and they called for it. Patients who were in the early part of the disease who could be seen by their GPs and sorted at that level. Another issue was language barriers. You know, we got calls from people from all sectors. It was not only one religious denomination. It was not only one racial kind. You know, people from all sectors called. And the amazing thing to see was, you know, the virus has evened the playing fields. So whether you were very wealthy or whether you were very poor, if there is no hospital bed, there is no hospital bed. Your money could not buy your hospital bed. Another challenge that they faced was that there were patients who were unable to get to the service providers. So, you know, you'd make arrangements for the laboratory testing to be done. You'd make arrangements for the oxygenators to be collected. You'd make arrangements for the pharmacy to have the medication ready, but these patients couldn't get there. So this was one of the other challenges that the triage team had to try and sort. They were juggling resources all the time, like we said, human and other, to get maximum benefit from it. And the reality is sometimes there was no resources to give. So their staff were not available and there wasn't the equipment. So there wasn't always oxygenators available. You know, so it was resource allocation. With regards to resource allocation, one of the things that comes to mind is the moving of oxygenators, for example. You know, when you're moving it from one patient who's complete with it, sending it to another patient, who's fetching it? Who's dropping it? Is there disinfection between? Are there new masks and or cannulae going with? Where does the patient get the new mask and the cannulae from? And the truth of the matter is the requirements were sometimes and most of the time bigger than what the available resources were that were at our disposal. As for the medics team, yeah, we were spinning, yeah. That's the truth of the matter. We were spinning. And still continue to spin, yeah. And the team consisted of general practitioners. We had a urologist, we had some physicians on board, we had a hematologist on board, an ENT surgeon, general surgeons, an orthopedic surgeon, an anesthetist, pharmacists, physiotherapists, nurses, phlebotomists, and caregivers. The truth of the matter is, it was a really diverse group of practitioners. And most of us were outside of our scope of normal practice. However, the WhatsApp group offered electronic support when it was necessary. You know, I think here take a second to mention that we're grateful to the specialists who were always available when we needed advice. The WhatsApp group for the medics team worked as a forum for updating information. So when new information would come through, new studies would come through and research would get published, this was the forum at which it could get shared with the rest of the group. It also offered internal communication between the service providers. For example, between the face-to-face team and the team that was doing remote care and between colleagues on the remote team as well. To touch on the medical legal aspects, the Health Professionals Council of South Africa has relaxed the scope of practice during the COVID-19 outbreak. They've even issued telemedicine guidelines. Good idea if you have a look at them, yeah? With regards to the Medical Protection Society, I think it's important that you ensure that you have cover. And unfortunately, we live in a nasty world and it's financially challenging for most people. And there are some that just want to make money out of it. So be careful, cover yourself, speak to the Medical Protection Society, tell them exactly what you want to do and ensure that you have cover. From our side, what we did is our administrative team spoke to a legal panel and they composed an indemnity form. So this indemnity form would be sent to all the patients. They would complete it and return this form, and then we would continue with the patient care. The face-to-face team, this is the team that would go out and see patients at their homes. So they would do the initial assessment and then order the investigations as were deemed necessary, depending where you were in the progress of your disease. If investigations, lab investigations were necessary, that they could get ordered. If treatment was necessary as per our protocols and guidelines, the face-to-face team would order that. And then once the patient was assessed and what was necessary to be done immediately would be done, the patient would then be referred back to the triage team, and the triage team would then allocate the patients to the team. I'm not sure if you can see this very clearly, but it's just an overview of the kind of information the face-to-face team would collect on their initial assessment. It's not at all in detail. It needed to be something that's adequate and yet something that you could pass on to your colleague, which would have almost all the information that was necessary. The challenges that the face-to-face team encountered, again, I'm going to say duplication. You'd always, or most of the time, you'd go there and there's more than one practitioner involved. And technically, it's not correct that if one practitioner is treating a patient without his or her consent or without consultation with them, to get involved in their medication, to criticize their medication, to criticize their investigations. But unfortunately, patients don't make it very easy. Lots of them don't disclose this initially. And when you get there, you'll indirectly find that this patient had this medication prescribed, or you'll find that this patient had been to the surgery already. It's something that you got to think about. Then was the issue of the PPEs for the team that was going out. And obviously, unfortunately, safety issues became a problem because you were going into areas that were allegedly not safer than others. Obviously, you were doing consults during the late hours of the night, and you were going out beyond the times of the curfew. Another issue was you'd almost always end up seeing more patients that were initially advertised or initially requested to go and see. So you'd get to a house and you'd go and see the patient, the principal patient, and obviously there's family members that are there, there's caregivers that are there, there's neighbors that are there, and you can't turn away from it. You inevitably end up seeing them. So your time that you've allocated there needs to be then spread over a little bit longer. Okay. The other thing that the face-to-face team did come into account, they did have to deal with, was you to have to go sometimes and help the patients to set up the medical equipment. I speak specifically about the oxygenators. And where did we get exposure to these oxygenators? We didn't, yeah? The first time you'd see it is when you were there with the patient. So like the patient is breaking their head with setting it up, so too are you. And it's different makes and different models, some Chinese, some local, So yeah, you'd have to know what you're doing, try and hook it up. It was a challenge for the face-to-face team. And then obviously the overwhelming numbers. The remote team was run purely electronic, predominantly using the WhatsApp social media website. Doctors would follow their patients from the admission till discharge, either from the face-to-face team or initially from the initial assessment from a telemedicine consult. Online consultation, online investigations, online medication, online follow-up, and even online discharge. We're living in an online age, aren't we? Okay, the remote team challenges that they had, you're dealing with lay people to give you clinical information. It's, for example, if you're wanting to know which patient to go and see first, one of the questions you'd ask is, have you got a pulse oximeter? What is the reading on the pulse oximeter? And the pulse oximeter usually come with two readings. The one is the saturation and the one is the pulse. And the lay people don't know this. So you got to explain to them which one it is, the one that says the percentage sign. So, simple little things, but you take it for granted. And lay people don't know. It's not their fault, The other issue was patients unable to access service providers. The other issue would be once you set up communication with the patient would continuously message. Patients are now at home. They're sitting at home. They're in quarantine, sometimes appropriately so and sometimes inappropriately so, asking sometimes pertinent questions and lots of the time absolutely unnecessary stuff. So, doctors that were preoccupied with their own jobs, many state-employed doctors, already overwhelmed, and now you're having the additional load of the remote consultations. Was good fun when patients would ask you about things that are not appropriate, especially if it's in the middle of the night. Okay, physiotherapy, an important, vital component. We saw the impact of it, and it made a huge impact. It was offered as a home service, so numbers of physiotherapists would get sent out. Patients who we thought needed it would then get these numbers. They'd contact the physiotherapists. They too were overwhelmed by the workload. They provided, both electronically, they put it onto the groups, online flyers with exercises that patients could do. So what would happen is they would go initially, do an initial assessment, do some treatment, and then hand the flyers to these patients electronically so that they could continue their treatment, and then obviously follow it up as they deemed necessary. Okay, let's talk a little bit about pulse oximeters. I know you're going to think it's crazy and super simple, but unfortunately it's not like that. The market has been flooded by them. There's various makes, there's various models, and the truth of the matter is some are really poor quality. Okay, they don't even work. Okay, the important thing to, if you're talking about pulse oximeters to lay people, that batteries need regular changing if they're used for prolonged use. Those little ones that you walk around with are not meant for continuous 24-hour use. They're meant for use, switching off and use again when you need them, yeah? But unfortunately, patients were using them for prolonged use, and because they were using them for prolonged use, batteries would die quickly and you'd get inaccurate readings. And it was important also to remember the trend rather than an isolated read. All right. Then the other thing is there's limitations to them. So patients who've got underlying illnesses, patients who've got nail polish on their fingers, those kind of issues, patients who've got peripheral vascular disease, those kind of things would give you false readings as well. So it's important to remember. This is not, okay, this is a bit over the top, but it's not an uncommon sight that you'd pitch up at the patient's home and they'd have 1 or 2 pulse oximeters on, and amazingly, they'd have different readings. The pulse oximeter, the saturation will be different and the pulse rate will be different. So which one do you trust? Okay, an important statement, let's move on now. Any patient requiring supplemental oxygen and or intravenous therapy is better off in a hospital. I think before the COVID pandemic came, any patient who required oxygen would be admitted in hospital. Any patient who needed intravenous therapy would be admitted in a hospital. Unfortunately, that has changed. Our hospitals were overwhelmed. Yeah, and there was a stage when there were no beds available, both in the private sector and the sector. To tell you, if I admitted him, I won't see him again. If he dies, he'll die a lonely death with nobody at his bedside. And the truth of the matter is, staff at the hospital were overwhelmed. And the patients would tell you, so I admit my family member there, who's going to take care of his feeding? Would make sure that he goes to the bathroom to relieve himself. Will he not die in urine and stool? And would take care of the patient's general upkeep? In the light of all of this and other issues, patients and families were opting not to get admitted in hospital. Do you respect their option, their choice? If not, what do you offer? So are you offering home hospital care? Okay, home hospital care. Let's talk about home hospital care. We said that oxygen requiring needs hospitalization. We made that a little bit less stringent. And we said that once you require oxygen more than what a generator can deliver, then you are a candidate for high care or ICU, then you definitely need hospital. The issue with this is that these patients can deteriorate rapidly. Not advisable to prolong their stay at home, and it provides a challenge for both the practitioner and the patient's safety. And most of the time, families don't have the capacity to support this level of medical care. So high care, setting up a high care or an ICU in your home is almost impossible. Let's talk about oxygen concentrators. Again, the market's flooded with various makes and models. And the truth of the matter is, some are just non-functional. It's important to know the maximum delivery capacity of these machines, whether they are 5-liter capacity, 7-liter capacity, or 10-liter capacity. You've got to be careful. Some of these machines, as you turn up the volume outflow, the purity drops. So there's a machine that you turn it up to 1 liter and it gives you 90%, and you turn it up to 5 liters and it's down to 30%. All right, so it's something to take into consideration when acquiring these machines at the onset. Some have single and dual ports, the dual ones being good for families where more than one person is ill at a time. The other thing you can do with these concentrators, I don't think it's recommended, you can hook them up in series. So for example, if you've got a 5-liter and a 7-liter and you hook the two of them up together, obviously by making a plan, there's no adapters for that, you could get yourself 12 liters of oxygen. Okay, just some pictures of the oxygen concentrators. The picture on the left is the normal run-of-the-mill oxygen concentrator that we were getting. The one on the right is the dual port, which has got 2 humidifiers. So you can connect 2 oxygen tubings to that and supply 2 patients. Okay, let's talk about oxygen delivery now. It's important to note the manufacturer's specification for optimal delivery. I'm talking specifically about the Venturi masks, the masks that deliver oxygen. In the masks, flow rate of oxygen determines the percentage of oxygen delivered. But that was calibrated from oxygen that was delivered from a hospital at almost 100%. Yeah? So it's not exactly the same when you hook it up to a generator. Another challenge is this virus has demanded a high FiO2 plus high volumes. How often have we before seen a patient with both mask and cannulae at the same time? It's not something we saw before. It's happening now. We spoke about that, nasal cannulae or mask. Which one are you going to use? Are you using them both? At what flow rate do you set it? And when would you start weaning it? This is an example of a Venturi mask and the different oxygen percentages. For example, the red one in the center is a 60%. It will deliver 60% if connected to the mask, but it needs a certain flow rate. The pink one will deliver 40%. It needs a specific flow rate. The yellow one will deliver 30%, and it needs a specific flow rate. And how do you know these flow rates? That's where it's written, at the bottom of the adapter. So if you look at the bottom of the adapter, this is a 60% mask. It's 15 liters per minute. So if you don't have an oxygen generator, and we don't have oxygen generators that deliver 15 liters, it's not going to give you 60% oxygen. Okay, the issue is then oxygen cylinders. It's another way of delivering oxygen, yeah? Firstly, they're difficult to manage. They're big and they're heavy. It's impossible for one person to carry them. They're dangerous. They're expensive. And you need regulators. Then you need a spinner to connect the regulator to the oxygen cylinder. Yeah? At the peak of when we were needing it, some companies were requiring you to have an account with them before they would supply cylinders to you. That could take up to 48 to 72 hours to set up an account before you would get oxygen cylinders. Some patients were beyond concentrator capacity, so they needed these cylinders. So that left you with a toss-up. Remember, we said initially, any patient that needs oxygen needs hospitalization. Then we lowered our threshold, and we said a patient who will manage on a concentrator will treat at home. Who won't manage on a concentrator needs to go to hospital. Now they're not managing on a concentrator, and we're happy to go with cylinders. So that's the toss-up between treat at home and admit to hospital. Patients who have been managed on cylinders, whenever the support was available, did well. Because you would get, I'm not saying the patients did well, I said the family support structure would make sure that you have the cylinders and the regulators. You know, at one stage, the service providers were overwhelmed, and they would only provide you with 2 large cylinders per patient per 24 hours. So you would have to juggle how you're going to use this oxygen, at what flow rate to make it last for that 24 hours. Then the patient would have to make a plan as to how he's going to get the cylinder, because you can't take both cylinders away. What does the patient then use? So you take one and you bring it back, and then you wait for the second one to get empty and you take it back. So you're running up twice in one day to get 2 cylinders. See the challenges? Okay, regarding the oxygen ladder, we just go through this again. It was recommended that you would start oxygen on patients whose saturation would be below 93%. You use oxygen generator to get the desired effect, and your desired effect would be 96% or more. Once a patient is stabilized on this level, you can then start weaning when the patient improves. What are the indicators that you must look out for if a patient needs more? Obviously, desaturation, and obviously, respiratory distress. Now tell me how remotely you're going to ask a patient or the family members of a patient if they've got respiratory distress. How many of them know how to manage the respiratory rate? How many of them know how to look for subcostal recession, intercostal recession, L and AZ flaring? It's something that the telemedicine group would then have to tell the patient's caregivers and get that information back. Okay. Okay, regarding laboratory sampling, Ideally, patients normally go to the laboratory to get their blood testing done. Either they're too ill to get there, they have no transport to get there, they have no funds or sponsors, and they need for follow-up. So it's not just a once-off bloods. You go there and you do bloods and you're going to need follow-up. So for that, a system whereby home sampling was done by nurses. They became available. Initially, I showed you a chart that the administrative team put together. And phlebotomists would come home to your home to do bloods. They were available, but they were overwhelmed. You'd wait sometimes a couple of hours, or you'd wait till the next day to get your bloods done. And then obviously the laboratory was overwhelmed, so you'd wait a little bit longer. So there was delays in sampling and processing. And then a new challenge, something that we need to start getting used to in South Africa, was load shedding. So you got a patient who's sitting there with his oxygen generator running at maximum, and you're going to have load shedding today. So what do you advise your patient? This is one of the flyers, or the flyer that we put onto the website, onto the WhatsApp group for patients, as to what they should do when there is load shedding. Okay, let's now move on to the medical protocols, yeah? Before I carry on, I have to acknowledge the contribution of Dr. F. Ahmad. She is an infectious diseases specialist. Those are her qualifications. Dr. Ahmad has come to the party, and she gave us guidance before any other guidelines were available to us. Yeah, as to what we should do and how we should do it. She's a specialist in the field. I'm not a specialist in this field. I'm a surgeon. What do I know about this? And in addition to giving us initial guidance, she would update the guidelines from time to time. And I say a big thank you to her as well for even assisting me with this presentation. Okay, let's go through the medical guidelines quickly. We know that the disease is broken up into the viremic phase and the hyper-inflammatory phase with hypercoagulability. The viremic phase is usually week 1, and 80% of people have complete recovery in the first week. Week 1, complete recovery of 80% of the people by the end of the first week. What do you need to do? What do patients get in the viremic phase? Initially, we were seeing fever, dry cough, myalgia, nausea, diarrhea, completely non-specific. The one sign and symptom that you could say in this day and age may be a little bit more helpful than the other was the loss of taste and or smell. What investigation did these patients need at this stage? All they needed to know was whether or not they had contracted the virus or not. So they needed a swab. Okay, now going to the viremic phase treatment. And there we go, ivermectin. I'm sure there's going to be many questions about it. $18 milligrams on diagnosis on day 1 and on day 3. And then the vitamin supplementation, vitamin C, vitamin D, zinc, vitamin B complex, and Ecotrin. Okay, regarding ivermectin. Ivermectin is not yet registered in South Africa. Okay, so obviously it's of limited applicability to us currently. It needs Section 21 approval prior to use. It is known to have potent anti-inflammatory and antiviral properties. Combined with doxycycline, doxycycline is synergistically anti-inflammatory and antiviral when it's combined with ivermectin. Okay, the issues about ivermectin, I'm not going to dwell into. Many webinars have preceded us where ivermectin has been discussed. 2 in this week, 1 last night by a professor from the Johannesburg General Hospital, and 1 on Monday night from a reputable medical professional in KZN. All right, and then the use of statins. And what do the statins do? They also have anti-inflammatory effect, immunomodulatory, and antimicrobial effects. Antimicrobial effects, I don't know how. We'll have to ask the microbiologists. Okay, the viremic phase is an active viral replication phase. Your immune response in this phase is protective. You should not give steroids. In this stage, do not give steroids. Okay, let's move on to the next phase. It's the hyper-inflammatory phase with hypercoagulability. And as we said, 80% of people recover within 1 week. So 20% of those who get infected will then enter into this phase. Again, the risk factors, we've lowered our threshold. We've lowered our threshold. Some will stay risk factors and it won't change. Diabetes, hypertension, cardiac disease will stay risk factors. The age has now changed. Initially, it was over 70. Then it went over 60. Then it went over 50. Now it's over 40. So I wonder what percentage of the population are now high risk. Okay, their symptoms and their signs. That's it. We're in a spin. It's completely non-specific. Okay, the important ones being oxygen saturation below 94%. And that was what would make you be concerned. What investigations would you like to do? Some are essential and some are recommended. The essential ones that we found, essential being what would alter your management. You could do many investigations, but if it's not going to make a difference to your management, why do them? The important and essential ones that were put onto the list for us were interleukin-6, CRP, it's not dimer, it should be D-dimer, and your procalcitonin. The recommended blood test, here you go, now you can start everything in, a full blood count with a neutrophil lymphocyte ratio, a urea and electrolytes with creatinine, glucose, AST and ALT, ferritin, and LDH. Okay? And obviously these patients need pulse oximetry. Pulse oximetry is not an investigation, it's management and monitoring. Okay, now we go into the nitty-gritties of the treatment. And we know that steroids have been in the front line of the treatment. Okay? Prednisone orally, 40 milligrams twice a day, or Medrol, 32 milligrams twice a day. Okay? We'll talk about how to use them, when to use them in the next slide. They need to be used with a proton pump inhibitor as prophylaxis for ulcers. Steroids are ulcerogenic, and you'd like to use a proton pump inhibitor, something like esomeprazole. Anticoagulation, initially was aspirin of 150 milligrams daily if there's no contraindications. And if the D-dimer was elevated to above 0.5, we would give a prophylactic dose of Clexane, enoxaparin. So how would you do enoxaparin? How many people know, lay people, how to give subcutaneous injections? Not many, yeah? So the alternative for that was Xarelto, which is a tablet, take 10 milligrams daily for at least 2 to 4 weeks. Supplemental oxygen. When would you want to start oxygen? When patient saturation was below 93%. How would you start oxygen? With the concentrator, we said. Start at 2 to 4 liters. Aim to get your saturation above 96. Escalate as per necessary. Antibiotics. Antibiotics only recommended if you suspect that there's superimposed bacterial infection, or if you have a procalcitonin that is elevated. Again, ivermectin and doxycycline, and then the statins, as we spoke about earlier. A guideline for the steroids, you'd start steroids if the patient was hypoxic, if the CRP was more than 20, and if the interleukin-6 was more than 30. If the CRP was less than 10, we were not giving steroids. Steroid dosing and empiric guide. There's quite a bit of information on the slide. We'd use initially 60 to 80 milligrams of prednisone orally or Medrol 32 twice a day. You repeat the CRP or interleukin-6 after 3 days. If it was improving, you'd reduce the dose by 25%. And you'd continue with the reduced dose, that's 75% of the original dose, for a week. You'd only taper after 10 days. And some even believe you only start tapering when the inflammatory markers had returned to completely normal. Okay? As a generalization, most of the patients were settling down within 10 to 14 days. The high dose of steroids is based on an observation from an article which spoke about the dose of steroids needed to treat COVID pneumonia appeared to be higher in the second wave. A too rapid a decrease or weaning in steroids was resulting in rebound. So be careful, don't wean it too quickly. Okay, this phase, the second phase, reflects an exaggerated pathological inflammatory response. So unlike the first phase where it was protective, here it is now pathologic and they needed intervention. Okay, the indications then for specialist consultation, hospital referral is a rapidly deteriorating patient at any phase of the disease. Severe dyspnea at rest or inability to speak in full sentences, oxygen saturation below 94, below 93, an alteration in the mental status of the patient, and patients in phase 2 who have not improved 48 hours after initiation of treatment, and patients who need systemic anticoagulation, full therapeutic dose, not the prophylactic dose. Okay, when would you escalate therapy at home? When you need to change from oral to venous to subcut. And then oxygen supplementation. We spoke about the concentrators. We spoke about cylinders. And then there's something called non-invasive CPAP. And then there's high flow oxygen. And then there's full-blown ventilation. This is a little machine. It's called the Cube 25 non-invasive ventilator. Okay, it's a new concept. It's almost like a home ICU. It's got CPAP and other modes. It's got a mode called PSV, pressure support ventilation, and bi-level S. I work in an ICU and I didn't know what that mode was. I asked many other doctors and anesthetists as well, and neither did they know what that mode was. But guess what? That was the mode we were using. So we had to go and research this mode, us in cooperation with the suppliers, see what the mode offers in inspiration, what it offers as far as PEEP is concerned, what do you change, which are the variables you change. For me, it has worked successfully on just one patient thus far. We've been successfully able to wheel the patient off it. There are other doctors who've used it and have got more experience than me. I'm not sure what their results are. And I'm not sure if it's a promising alternative if no ICU bed is available. It's labor intensive and the suppliers offered the help when they could. Okay, let's touch on some ethical issues. The reality is many people are dying. When you die, you have no control over. How and the condition in which you die, you sometimes choose. So you may choose to die at home or in hospital. You may choose to die with loved ones or alone. You may choose that your feeding needs and sanitary needs are taken care of or not. But that is all weighed up against whether or not you're getting specialized medical care or not. So these are the kind of ethical dilemmas that you were faced with. Those decisions leave for the family to take the decisions. You give them the facts and let them take the decisions. Okay, the issue of death. The truth of the matter is there's an unusually large number of people dying at the moment, and sometimes more than one person per household. Patients don't read textbooks. Okay? I say this because we've seen young, healthy people with no comorbidities and don't fit into the high-risk group that have contracted the disease and have died. And we've seen old, frail patients who've survived. So what is our responsibility? Our responsibility is to pre-warn the family of possible outcomes. Important to get psychosocial support early to assist with bereavement. As far as documentation is concerned, the death certificate, there's COVID-related and COVID-associated deaths. Just be careful. If it's by the way that you came and you got admitted, for example, for burns, and then you contracted COVID, it's not COVID-related, it's COVID-associated. All right, so be careful of that. Okay, I'm done. And I think we'll address the questions later once I go through the conclusion. Is that okay, Prof. Musa?
Yes, go ahead.
Okay, conclusion. 2021, yeah? We claim that we technologically advanced, yeah? A microscopic virus has turned the world upside down. Really, it's turned everything. Finances, economy, education, health, everything upside down, yeah? We need to acknowledge our weaknesses and inadequacies. Point one. Point two, there is so much of mumbo jumbo around. Compliments of social media, you know, it's unbelievable the kind of stuff that comes out. We pray that we saved from it and we don't act on mumbo jumbo and give our patients what we would expect done to us. Hear me carefully. You do for your patients what you would expect would be done to you. Point two. Point three, our little actions in trying to help people, we pray that it brings the mercy of that being that has brought this disease and that controls the heavens and the earth. Thank you very much.
No, thank you very much, Dr. Ganchi, Jazakallah khair, and thank you for everyone. I know this is very useful in the sense it gives insights into a group of doctors who are doing things on the ground in very unconventional ways, unconventional spaces. But I think there's learning, whatever the controversy. So I think one question that's popped up by Dr. Owen Eels from Chwane is about the public service potentially with outreach teams who do home visits. Is there a possibility for the public service to set up such a service, including potentially making oxygenators, etc., available? Feroz, you are part of the public service. I know you're not at a district level, but what are your thoughts about the public service thinking like this?
I think, unfortunately, the public service at the hospital where I work, I speak for that hospital. We are a tertiary / quaternary hospital, yeah. And the COVID patients that come to us for ventilation, to the COVID ward, or patients that have been admitted and test positive for COVID, then go to the COVID wards, yeah. So there hasn't been any initiative, as far as I'm aware, of the hospital that I work at that has made any efforts towards community projects like this. Regarding the Department of Health, KZN, I'm not sure. I cannot comment in that regard. I don't know.
I know it's actually, you know, often at time this public service is stretched as it is in terms of trying to deal with what comes to the door. So I think that Owen, you are probably in a position to try with the strength of what you're doing to be able to see if you could do that yourself. Because I mean, if you look at what Dr. Ganchi has presented, it is not impossible for us to be able to create such a service. But I think the key challenges that is laid out is having nurses, enrolled nurses potentially doing phlebotomy, doctors who could be either on remote or on visiting. So it's potential, and I think the equipment is potentially could be there. I think the one thing that might be lacking in the public service is the focus on cylinders and piped oxygen as opposed to concentrators, which are probably easier to get into homes, in your reach. So I think if I can tell you that is, I think, potentially a problem. I think there's also a question about the recording. I've just put on the link that you can get this recording, so you'll be able to see what is going, the details. I also will share the protocol that was the presentation Dr. Ganchi has given to me. I'll put it up as well, and then the protocol from Dr. Ahmad. I will put up, Dr. Ahmad, Farida Ahmad. I'll put it up so you can have a look closely at the details of her proposed, protocol. There is also another protocol which is also kind of useful from Donny Gordon that was presented a few days ago that you might look at as well. I'll post that up too, so you can have a look, see at how do you manage patients proactively at home, and not just wait for the hospital to be able to manage the situation. I think Colin has raised the issue of funerals and parties being super spreaders, and I think that's really valid. And I think that we've seen the topping of our surge largely because of the lockdown blocking these large events. So I think the government needs to actually think, and I think alcohol has really been a major thing. So I think the government is becoming much more clearer about what really to do to try and cap the spread. I mean, they should have thought of this even before the holiday season. So each of the holiday seasons are going to have to be damped down quite considerably to prevent travel and gatherings and the kind of recklessness that we saw over December. I think that led to sort of doubling the numbers of the last July surge in KZN. So I think Western Cape and KZN saw the brunt of it. And I think that we really take our hats off. I think one of the comments is in is that it's an amazing session. And Maria, thank you for that compliment. Dr. Ganchi, thank you very much. I want to ask one or two questions, I think, just to take us to the hour, and I think that should be enough. A key question, and it's really interesting. I don't know whether you have that kind of data, Dr. Ganchi. What sort of numbers did you all manage? And what were the sort of patients who you landed up putting onto concentrators? And of that you put on concentrators, delivering the kind of levels that are available, how many of them did you land up saying, they're not resolved, we have to admit? And I think that speaks to its success, perhaps, that those are potentially patients who are landed up in a hospital, and yet you've been able to manage them in home. Would you be able to share that data? Do you have some sense of it, even approximates if you don't have the exact?
I don't have exact numbers.
Sure.
I'm sure if I go to the administrative team, we have a good database of what number of patients have required oxygen concentrators. We have a good database of which have been discharged with full recovery. And then there's obviously those that get admitted. I'd be lying if I were to tell you exact numbers.
In your experience, I mean, you've been quite on the ground. I mean, how many of the patients that you've put on concentrators did you land up saying, I have to admit them, or they got admitted because they couldn't be managed?
Most of them have gotten sorted, We've had a couple, like I said, I've tried the non-invasive ventilation. I've tried it on only 3 patients. It was successful on 1 and not on the other. So, the ones that didn't manage on the concentrators would either get tried on the CPAP machine or get admitted. Look, I mean, a fair amount of the patients that we saw did get admitted. And then a fair amount of the patients did get discharged and did well, The other thing that we're starting to see now is that patients that are getting downgraded from hospital. So they were previously admitted at the hospital, they're getting downgraded, and now it's for us to follow them up. That's new. In the last couple of days, that's now been new, So that's another. But regarding the exact numbers, I apologize. I don't have the data at hand.
Well, I mean, your sense of it is actually useful, that, if it's half, at least that's quite a substantial number of people who've been saved the challenge of being admitted and the trauma that's involved. So I think that's still very good, but it'd be interesting to share those numbers, I think, just to show the experiment and write it up. I'm sure that one of the journals would take it as a small report of the experience. So I think share that in public spaces. I think there is a global movement, and I think in the US particularly, about embracing home care. And I think that you've done it, under duress. I think the COVID's forced all sorts of things to change. This kind of monitoring equipment that you talked of, what can we replicate reasonable hospital care in the community? There are companies now that actually provide it. Do you all think that this is an impossibility to go forward with, to be able to do some of that stuff in the community more robustly, where you felt challenged before? Do you think of the next wave that you'd be better prepared to take it further?
Look, I think the initiative has grown. Like I said, initially it was just the intention was to fund people who don't have funds, And obviously that grew, and it grew much bigger than we expected it to grow. There was a stage where we sat down and we had a discussion, and obviously the senior people in the group as to how much bigger should we let it grow. Currently we're limited to the Durban Central area. We've got 1 or 2 doctors who are based in the south that are working there. And had we allowed it to grow, it would have probably eaten us up. We wouldn't have managed, and the quality of our care would have dropped, And I think with all of us expecting the 3rd wave to come, I've heard it on 2 webinars now. One of the professors mentioned yesterday, and previously as well on a webinar previously, that we're expecting a 3rd wave probably in the area of May to June. And I think that we should learn from this exercise and be more prepared in the 3rd wave. So not knock our head again and set up these little projects. Big projects don't work because it takes lots of administration. So even little within a community, the local doctors in that community can take the project forward. I think the people in that community will benefit, and that's what it's about. It's benefiting the people of the community. And like I said, the playing fields have been leveled. So whether you Mr. Millionaire or you Mr. Pauper, if there is no hospital bed, there is no hospital bed. Your money can't buy it. and that home care is what you're going to need. So if the doctors come to the party and they provide the service, I'm sure they'll make a difference to the community.
And there'd be a lot of people who'd probably be donating if they think that, hey, hang on, I might be faced with that challenge. I've got lots of money now, but I could be dead in 6 months' time. So work on that one to raise some. So I think there's plenty of opportunity to explore it. I know that you'll have looked at a national sort of networking. I know you invited me to that group. Is there some progress with doctors? We have got doctors in the Joburg area that are in this call, perhaps elsewhere. How might they benefit from that network? Can you share a little bit about it?
There are groups that are trying to spread their wings nationally. Our senior, one of our seniors, has engaged them in a meeting. Like you said, I invited you to the meeting as well. Medical organizations and relief organizations, where they want to set up national call centers, so that we can coordinate it on a national scale.
That's right.
Currently, we just an outshoot of theirs.
Yes.
So if they have bigger numbers, they'll downscale to us, or they'll send patients to us for now.
Yes.
We haven't been swallowed up entirely by them. I think we're quite stingy in that we've gotten comfortable in our little corner, working with the people that we're working in. But I think either it must be that you get comfortable in your little corner with your group, and then affiliate to a bigger group. The advantage of joining a bigger group is there's always more resources available. Like for example, if we'll have a pool of maybe 5 oxygenators, if you join a bigger group, your pool gets bigger, and you can reach out to further, and you'll have maybe 2 doctors doing face-to-face consultations. Whereas if you join a bigger group, you'll have more doctors doing face-to-face consultations, more laboratories come on board, things like that. So there's obviously good in big groups. It's just we're scared of the administrative things that go into managing these big groups. As it gets bigger and more complicated, the administrative duties become much, much more. And I mean, the group that we've got also, the administrators are doing it all free of charge. There's nobody's taking any reimbursement for it. So it's people who work, and at the same time as they're working, they manning their WhatsApps so that they can get some of the work done. But there are organizations, like you said, that are doing it full time and have got full time call centers available. And I'm pretty sure they're much more professional than us.
Well, I'm sure you'll share with me, any contacts you have if they are in Johannesburg. But I think that if anybody would like to join this group, I think please do so. I think there's going to be more need as we're going along. I think in closing, I want to say, Dr. Ganchi, on behalf of the Joburg Department of Family Medicine, thank you very much for sharing this. Please tell your colleagues well done, and thank them for their sharing as well. So with that, I want to say thank you to all of you who've joined us this afternoon. I hope this has been useful. We'll share the recording, the protocols, and any other information that is useful on the web page that advertised it. I've put it out onto the chat group, so you can have a look at that. But thank you very much to all of you. And I think there's some information as well about COVID. I mean, about ivermectin. So please keep tabs. I think there's lots of pros and cons and discussion around it. So please keep tabs. As Dr. Ganchi said, we won't get into the details of it. Many of the time we have to deal with information or misinformation in the community. So I think let's be keeping an open mind, but observe what Dr. Ganchi talked of. Do no harm first, and then do good. So thank you very much, Dr. Ganchi, Feroz. Thank you, and thank you all. Bye-bye.